Hello, everyone. Greetings from Jacksonville, Florida. This is Mike Ackerman, genetic cardiologist at the Mayo Clinic, normally in Rochester, Minnesota, but now for the last week and a couple weeks here on Mayo Clinic Florida's campus in Jacksonville. Great to get to be with you for SADS Live 161, where I give you greetings from our CEO of the SADS Foundation, the Sudden Arrhythmia Death Syndrome Foundation, Alice Laura, and her incredible team. And like last time and the previous 160 times, we're here to help you live and thrive despite your genetic heart condition. So if your home is SADS Foundation because the name of your condition is long QT syndrome, I love having you with us. If it's Brugada syndrome, we love you. CPVT, that's a long, short acronym, but a long phrase, catecholaminergic polymorphic ventricular tachycardia. Or maybe your home is ARVC, arrhythmogenic right ventricular cardiomyopathy, and that's your disease name, and you find the SADS Foundation your home. We love having you as part of the SADS family. Whatever is the name of your disease, if you find comfort, confidence, encouragement, knowledge from the SADS Foundation, we're here for you, and Alice and her team are very committed to you. Our primary number one focus is you. That's knowledge, power, connection, support, and we try to do that as well as we can. I have had the privilege of serving as president of the board of the SADS Foundation since 2006. SADS Live was incepted around, February, March of 2020. And today's purpose is your questions and my answers. Your questions are always inspiring and amazing, sometimes long. So look on that sidebar and keep them short so I can quick glance at them. And then I'll try to give you good answers. Remember that my answers are not about you specifically. I can't give direct patient advice, hardly can know anything about you exactly in a short question, but I'll try to use that question to unpack and illustrate some of the important issues. We are February, as you know, if you know what February is in the United States. Yeah, Valentine's Day, happy Valentine's Day last Friday. Yay, my second son and Catherine got engaged last Saturday. So I will have another daughter-in-law in the near future. So the Ackerman family is very excited about what February means for us. But for us, the community of heart individuals who not only have a heart, but have a heart with a special name to it, it is National Heart Month. So we join American Heart Association and the other organizations to declare the need and the desire for increased awareness about heart health. Do you know your history? Do you know your story? Do you know your family history? Because that family history may not just be important for the past, it may be very important, life-saving for the present and the future. And next week, we have Rare Disease Week within National Heart Month. And so we'll have some things out about that. Now, if you're looking on your calendar and you have nothing to do on Saturday, March 22nd, and you want to head to Nashville, you can go do Nashville, and at Vanderbilt University, our in-person SADS gathering. I won't get to be there. I will be on Mayo Clinic Arizona's campus for during that time frame. So anyway, those are the announcements, and we are going to start with your questions. And there are a couple have come through already. So welcome wherever you are. I'd love to see your name and where you're from. And some of you, I saw just one of you SADS Live individuals on campus this week for your appointment, and what a privilege it was to meet you and how you found us for your child's care through SADS Live. So that was a special 360 experience. So Diana is asking, what if you carry the gene, but you've never had a cardiac event and you're young at age 77, but your grandson died from long QT, either type 1 or type 2? Does this mean I have it or just carry the gene? That's a great question, Diana, because there's a lot of confusion. You'll see the term carrier used in genetic heart diseases. And most genetic heart diseases, I don't like the term carrier. It's actually an incorrect term because usually we use the term carrier for diseases like cystic fibrosis, where it's what's called autosomal recessive. You need one copy from mom, one copy from dad, and the child needs to get both bad copies, and then they show the disease. Meanwhile, the mom who carries one and the dad who carries one, they are carriers. But we should not use that term for long QT syndrome or Brugada syndrome or arrhythmogenic cardiomyopathy, CPVT, because if you own the mutation, you may never show it, but we cannot call you a carrier unless we absolutely know that it's impossible for you to show it. So those who own the mutation, I don't use the word carrier. I call you genotype positive or variant positive. But if you don't show it, meaning I can order every clinical objective test that I know and everything is normal, 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 then we describe that person as genotype positive but phenotype negative. Now that person is at super low risk, but that doesn't mean they're no risk. So for example, at your young age, Diana, a person who owns the mutation, but it's never revealed itself, they may not need treatment, prophylactic medicine and so forth, but they need to take some precautionary measures because it's possible that although dormant for 77 years, if somebody put that person while sick on a QT prolonging, a QT agitating medication, all of a sudden what was dormant for 77 years can become tragically explosive. So if you own that mutation, you own it. Then it's up to us to determine how easily is it that you show it. And if you show it easily, we treat it well. If you don't show it, we give preventative measures to advise. Merrick is a number 2. When are PVC RT dangerous if the ascend at the top of it? So now that's a great question. It's pretty technical. And what Merrick is asking about is when is a PVC, which is a premature ventricular contraction, your doctor might have told you at about a skip beat, an extra beat, a premature beat. And when that's coming from the bottom chamber, the ventricle, we call that a PVC. And then Merrick is saying R on T. Now that's a descriptor of when that skip beat is striking during the previous heart's electrical cycle. And if it strikes in this vulnerable window of time during the T wave, which is the electrical recharging of the heart, and usually on the downslope of the T wave and early, that kind of timing is the more likely timing where it could, as they say, upset the proverbial apple cart and trip up the heart's electrical system to not just be one skip beat, but that skip beat could cause a cascade of irregular bottom chamber beats that we would call, in the case of long QT syndrome, torsades de points, which is a French term for twisting of the points. So it turns out that there is a window of time, and the earlier it is in the downslope, the more vulnerable it could be. Now, for most of us, that doesn't matter. So if that was too much for SADS Live, we'll move on to the next one. But I like the question. And Merrick is from Poland, and oh, I love that. Honestly, I'm not sure I've ever been to Poland. I've got to put that on my bucket list. Kim is asking for question number 3. If you have Brugada, does that make the chances of other heart issues? Well, for Brugada syndrome is mostly an electrical glitch where mostly we have to wonder and assess whether there could be bottom chamber rhythm issues. Bottom chamber rhythm issues, another word for that is ventricular bottom chamber arrhythmias, rhythm issues. And so we monitor your risk to see if a person with Brugada could ever have a Brugada triggered arrhythmia that would make them faint and then wake up, or faint and do worse. And so then we would counter that threat accordingly. Now, we thought for a long time that it was just this electrical thing, the ECG Brugada pattern, but we now know that in some patients, we need to monitor their Brugada heart to make sure that the pump is staying strong and that the pump does not move to a cardiomyopathy that we specifically call dilated cardiomyopathy, or DCM. Pretty uncommon, but we now do periodic imaging monitoring of our Brugada patients and not just heart rhythm monitoring. Boy, we are off to a great start on this Friday, February 21st. And let's go to the next. Mavis received an ICD on April 22, so almost 3 years ago, going through twice lead fracture. Oh, I'm having muscle spasm. Any way to overcome it? That's a tough one, and that's a really good one. I won't speak to your scenario again. There's a lot of things I need to know. But in general, when I use an ICD, an implantable cardioverter defibrillator, I try to tell my patients that the ICD, as best I can determine, is the right recommendation, just like I recommended today for a wonderful young mom, not a symptom yet, who has both an FLNC truncation variant. Some of you may be aware of that if you are an FLNC cardiomyopathy, and a DES. So for her and her husband and their children, we felt together that we need to intervene. And I always tell all of my families that when we do an ICD, that is a for now recommendation, not a forever one. And I like that thinking of it because we may learn more. We may come up with better options. We may learn in the future that we overestimated the risk and the disease behavior, the forecast is actually not that bad. And yet we thought it was 5 years ago, 10 years ago. So it's a for now. And when do I reassess the wisdom of that recommendation, or that, and that is when the risk benefit balance tilts in favor, out of favor. Remember that scene in National Treasure where Voight, I think, said to Nicolas Cage, the status quo has changed. So when the status quo has changed on us and we've hit the tilt button in terms of risk benefit, then I always pause, reassess, and say, now what's the score? So I've had patients, for example, where we thought it was a great idea, but then we paid the piper for one ICD complication after another. And ultimately, we reconfigured the strategy to where we chose to remove the ICD. There might be other scenarios where now that we have 4 different ICD configurations, that we might switch from one type of an ICD architecture, strategy, design to a different one, not which company, but which type of ICD. So I would, anytime we have a complication, I think about it and we make a decision. Okay, we're going to deal with the complication. Anytime, on the flip side, we have other patients who get a shock from their device because the disease misbehaved and it was a correct shock. A lot of times the response from the doctors and the healthcare environment will be, see, that's why you got the box and we don't need to change anything. I view every shock, correct or incorrect, as a call to action to where I need to think about it and potentially we might need to change things, revise things. So best wishes with navigating that one. Kim's follow-up, can I please explain, because I don't understand, my daughter's EKG shows Brugada pattern type 1, no symptoms, but another person shows same and had a cardiac arrest? That's a wonderful question. And that's what's so important about these diseases. And there are other genetic heart diseases, say, for example, one called HCM, hypertrophic cardiomyopathy, where the behavior of that disease in that family, in those relatives, directly informs and impacts the forecast, the prediction of that disease's behavior in you. In other words, the family history is a personal risk factor. What's important about that statement, although completely true for HCM, it is not true for almost all of the channelopathies like long QT, CPVT, and Brugada. And so what we've learned is that in the electrical diseases like Brugada syndrome, its behavior in other relatives, although we document it and we note it, doesn't impact how it will behave itself in another owner. And so we've learned that each owner for those kind of mutations have other factors that help influence whether the expression is going to even be there or not there, like the 77-year-old grandmother where nobody can seem to see it. Or if it's there, is it there mild, medium, or spicy? And so just because the family owns it, they don't have to all declare the exact same version of it. And so the family history, good or bad, it doesn't impact or supersede the importance of carefully evaluating you, the direct owner. So it's not a surprise at all that it could be minimal in a daughter, but have shown itself in another person with cardiac arrest. Every individual needs to be evaluated carefully and comprehensively, and no family member with long QT, Brugada, or CPVT should be penalized with aggressive therapy, meaning get a defibrillator installed because, let's say, it caused a tragedy in an aunt, uncle, cousin. That death, tragic, yes, but directly informing how aggressively I should treat the patient in front of me, we shouldn't be doing that. And we have over-implanted and over-treated individuals because of its declaration in other relatives for these diseases like long QT and Brugada and CPVT, and we should not be doing that. Nicole's asking me whether you can have a longer QT interval during puberty going in teenage years with your daughters. Well, first, congratulations. The teens are amazing. Refuse to call them terrible teens. We call them terrific teens for all four of our kids, and we were 4 for 4. So a lot of life is mindset and attitude. Now back to the original question. That QT number can change. It changes in all of us. It's very dynamic. It can fluctuate throughout the day. It can fluctuate based upon excitement or not. It can fluctuate based upon potassium levels, high or low. It can fluctuate. A lot of things influence it, but most of us have kind of a swing in that thermostat reading. What is your QTC? And you should know your QTC, just like a diabetic should know my sugar is, and in this stressor, my sugar level became glucose and whatever. I want my patients to know their QTC. And then that way we can talk about what is the risk? What are we doing to counter the risk? Now, can that QT number change more significantly outside the normal range in certain periods of time? And one such period is the transition in and through puberty, where we know with the arrival of testosterone in our boys, the QT number can potentially shift to a shorter range than what it was fluctuating between. Whereas after the arrival of estrogen in our girls, that QT number could nudge a step higher. Does it turn out to be a big step up with estrogen? Not really, but we check on it. And even we know, and this is work from a dear friend of mine, Arthur Will, and his team, that where a young woman is in her menstrual cycle, the QT might be slightly different. Is it before ovulation, at flow of menstrual cycle? And so the different hormones affect the QT interval. So what we do in my program at the Mayo Clinic is when my young girls, I tell, this is our drill. It's not proven as necessary, but it's what we do, is that when our girls transition in and through menarche, having the start of periods after their third such menstrual cycle, so that we know it's kind of established, then we have them get an ECG, now that they are no longer a girl, but are a young woman. And then we look at that and say, okay, did estrogen significantly alter, change, move, increase, so that maybe what I was content with my treatment strategy when they were a little girl, I might have to modify it slightly. And usually that modification has been very mild. Every once in a while, we've seen a dramatic change with the arrival of estrogen. So we do that safety check. Hasn't resulted in frequent changes, but that's the safety check that we do. Sophie, let's see. Sophie would like to know if the results of the study about the effectiveness of mexiletine in LQT2 patients that my team and Peter Schwartz that we published last summer, so about 8 months ago, can children with type 2 be treated with mexiletine? Oh, I love that question. And the answer is yes. I treat a lot of patients, regardless of age, boys, girls, men, women with LQT2 with mexiletine. Now, mexiletine is an incredible story that 30 years ago, almost 30 years ago, 1996, Peter Schwartz was the first to really do genotype-directed therapy. 1995, sodium channel mediated long QT syndrome, you know that as LQT3, was discovered. A year later, Peter Schwartz published his experience using mexiletine for LQT3 specifically. And then that was amazing if you think about it, that long ago, to do genotype guided therapy. Now we do that all the time. That was pretty radical, pioneering 29 years ago. We had an idea in 2014 in my program that mexiletine might make sense for some of our long QT2 patients. And we had some ideas as to the why, and we published our experience showing that there was significant shortening of QT interval in some, not all, some of our LQT2 patients. And then our program has continued to do that for the last decade. And we combine data with our experience of using it in LQT2 with Peter Schwartz, who after that 2014 paper started using it as well. So bottom line is I like mexiletine a lot in LQT2. I like it a lot in LQT3. And who do I use it in? I use mexiletine in LQT2 patients who either are experiencing breakthroughs, meaning their long QT2 is doing danger rhythms despite their current treatment program, or having an ICD shock. So then I'll add it on. It's a treatment intensifier. Then I also use it in my LQT2 patients, not as a treatment intensifier, but as a preemptive strategy in those where their QT number, their QTC, remember, know your QTC, is consistently above 500 milliseconds. And in them, I'll use it to try to get that QTC number lower, because the lower the number, the less flammable the long QT substrate, meaning the less likely the long QT mutation is going to explode into a danger rhythm. So I'll do a preemptive move in somebody who's never yet had a symptom when I don't like the forecast. Incredibly well tolerated. And we're going to see it more and more. Don't need to use it very often in type 1 long QT syndrome, but we're examining the data, our program, and again, Peter Schwartz and Leah Crotty, in the handful of situations where we've needed it. But in LQT1, we seldom need to have extra therapy besides a beta blocker or denervation for their effective protection. Again, if this treatment program doesn't result in unacceptable side effects. Let's see, QTC is what I think we did that one. Jennifer, ooh, this is a good one. How successful is ablation in CPVT patients who've reached their maximum dose on nadolol flecainide, but they're still having refractory ectopy? Ooh, that is really good. I'll tell you that the number of ablations that we've done in our patients with CPVT in 25 years, I think, is dose 2. We don't need that strategy. So really, for when I'm not getting control of their rhythm, as you know, for my CPVT patients, our goal is increasingly to make their stress test so normal that we would not even be able to know or guess that the CPVT mutation is there. And often when the ectopy persists, the number one reason is that we haven't dialed up the dose of flecainide well enough. So in all of my patients, I do a flecainide trough level combined with their stress test. So I know that at what level in their bloodstream do I need to achieve to get that stress test normalizing effect. Now, if I'm at a great level and I still don't like the stress test, those have been a couple of the settings in which we've explored doing ablation. So when you're talking a couple, it's really hard to declare success. For me, before I would do ablation, if I had a stress test that I still did not like after nadolol and flecainide, we would be adding, for that patient with CPVT, triple therapy with the addition of left cardiac sympathetic denervation. Howie's asking me all these questions. Wow, we're on fire today. What is my view on SCN10A mutation? I understand there's conflicting data about this mutation and really about this gene. And that is a great question. And you're right, there is conflicting data. This has been very confusing and a bit frustrating in the Brugada land, for example, because in Brugada syndrome, what's quite unbelievable is ever since the first Brugada gene was discovered, I think 1996 might be the official discovery date, where loss of function mutations in SCN5A, excuse me, was implicated in Brugada syndrome. And remember, we said earlier that SCN5A mutations was discovered in 1995 as causing LQT3. Well, LQT3 SCN5A mutations are different. They make the sodium channel leaky we'll call it that. Whereas Brugada SCN5A mutations damage the peak performance of the sodium current, decrease it, and that's why we call that a loss of function. And then subsequent to SCN5A Brugada syndrome, over the last 25 years, there were 22 other Brugada genes published. And my lab published a couple of them, new genes, not mutations in SCN5A, different genes like SCN10A, like KCND3, like GPD1L and so forth and so on. Well, what has happened over those years then is an entity called ClinGen started to do essentially a scrutiny of the data. What is the strength of evidence to implicate that gene as the cause of that disease? And we called those a disease gene association. And out of that vetting, they published a report, I was on it as well, where only after all this time, all of these discovery papers, only SCN5A was voted guilty as charged, enough evidence to declare it a monogenetic disease gene. And even that is a slightly wobbly. We won't talk about that right now. But the other genes, including SCN10A, got demoted to insufficient evidence disease genes. Now, it turns out that some variants markers in SCN10A are becoming part of what's called the polygenic risk score, or PRS, for Brugada susceptibility. Over time, it's being realized that Brugada syndrome is not very often a monogenetic hit. One gene, one mutation in that gene, enough substrate for Brugada syndrome. It's influenced in what we refer to as an oligogenetic or a multi-hit process. So the biology of SCN10A and what that protein does to either what the protein does or what the messenger RNA does to influence the level of the SCN5A sodium channel alpha subunit, which is the major sodium channel alpha subunit of the heart. It's fascinating science. Probably went a little bit deep in the weeds there, but Howie, I think that I haven't seen your name before, and it was worth, hopefully you enjoyed a little bit more detailed answer. Let's go to Dark Moon. That's why I suspect it might be a nickname. I don't know, but we're learning that we have symptomatic LQT1, been on a good dose of Nadolol for 30 years, 29, and we're now 40. So we're treated since we were 11 and getting married this summer. Ooh, awesome. Joining my son, who will be getting married as well, and wondering what are the chances that my children get LQT1. So this is relevant to virtually every one of our disease genes, whether we're talking about LQT1 or LQT2, LQT3, CPVT1, PKP2, ARVC, and so forth. These are called autosomal dominant diseases, whereby in you, for example, in a man, for example, half of your sperm own this genetic marker, in this case, the LQT1 mutation. Half of your sperm do not. In the females, half of their eggs own the marker. Half of their eggs do not. By marker, I mean the genetic variant, the disease causative variant. And so for every child you create naturally, each child has a 50-50 chance of originating from the sperm with the mutation or the egg with the mutation. And so the short answer is it's a coin toss. It's a 50-50 chance. Now, remember, even if you own it, you may not show it. So again, ownership only creates the potential of declaration of the disease. But when it comes to procreation in these diseases, it's basically a 50-50 chance. And Carrie, if you are on a good beta blocker, is it protective against meds on the credible meds list? If not, why? Oh, I love that one. So this really gets to long QT syndrome, because it's really only long QT syndrome patients where the credible meds list is relevant. And she's referring to this website, www.crediblemeds.org. If you have long QT syndrome, you should have that website. you should have that app downloaded. On the other hand, if you have Brugada syndrome, you should be going to the website www.brugadadrugs.org. So for long QT syndrome, credible meds, Brugada syndrome, brugadadrugs.org. This is your friendly list of medications implicated to be either QT agitators or potentially Brugada agitators. And whenever possible, those medications on the QT hit list, crediblemeds.org, should be avoided. Now, what I like about your question, Carrie, is are they absolutely contraindicated? And in our program, the answer is no. These medicines should be viewed as timeout. But do I have patients with long QT syndrome who are well treated, or where their risk is so low I don't think they need to be treated, where I have permitted, empowered them to be on such a medication? The answer is yes, a lot. So I have long QT patients who have struggled with anxiety and depression, and they're on a medicine on that credible meds hit list. I have patients with long QT and concomitant asthma, and they're taking their albuterol. Albuterol's on that list. I have patients with long QT who are struggling, suffering from ADD, and they're on stimulant therapy. Guess what? Stimulants are on that list. So we don't treat just the heart, and I try to treat the whole person. Do we want to know that list? Do we want to make sure that we're not inadvertently treating that person with 1, 2, 3 drugs that happen to be on that list all at the same time and then create a perfect storm? But the beta blocker treatment of your long QT itself doesn't necessarily protect the heart so well that we can just throw any QT agitator at it and not worry about any possible repercussion. Last question gets to go to Lisa, and I will use that because that's the first name of my wife, who, by the way, is flying in today. Don't worry, the house is secured. Somebody's there. Anyway, Lisa is asking about the QTC, and she's giving me her number, 470, and it's classified as long QT. Is it a concern? We could have a full session on what is your QTC, when does it matter, and here the QTC number is a measurement as to the health or the efficiency of the heart's electrical recharging system. And we all have our number. That number fluctuates. We know that that number is different before puberty. We know that number is different in men versus women overall. We know that lots of diseases will nudge that number to the right. And so, for example, for a woman, the average QTC at rest, say a 12-lead ECG done at 8 in the morning, the average QTC among women is about 420 milliseconds. That's the average. We know that the boundaries that will capture 99% of all women would let it go from, say, 360 to 480. And that would capture 99% of women. Whereas if instead of doing a morning ECG on healthy women, we did it on long QT patient where we know they're positive for a long QT mutation. And now we ask, what's their average QTC? Well, among all of my patients, and I've had the privilege of caring for about 2,000 patients with long QT syndrome, their average QTC at 8 in the morning, 12-lead ECG is not 410 for the women, but now 480. So the average is now at what would normally have been the 99th percentile value. So 470 gets interpreted depending on the context that it keeps. So if you have a mutation and you're 470, well, then you're at the 50th percentile of all of my long QT patients. If on the other hand, that 470 is in somebody who is otherwise healthy, there's no diseases present, there's no story of concern, there's no family story of concern, but somebody is labeling that person long QT syndrome just because that number is 470, then we need to do a timeout and a rewind to reassess the strength of the evidence. And that sound was the sound of the top of the hour. And that brings us to the end of SADS Live 161. And guess what? We're meeting again, I believe, next week. We get a 2-week in a row one. So I can't wait to be back with you for our next SADS Live. And until then, live and thrive despite your heart condition. And if your heart is a healthy heart and you're a family member or a doctor who loves taking care of you with a SADS condition, let us all live and thrive this week. Take care, everyone.